Well, hey, I hope you guys are having a great day, and I want to welcome you to your mental health class. Today, we're going to be talking about trauma and stressor related disorders. So let's go ahead. Let me get our PowerPoint up, get it showing here so we can get on. Righty. Okay, as I mentioned, this particular lecture is going to be on trauma and stress-related disorders. As we go through this particular lecture, we're going to be focusing on 2 trauma-related disorders, and we will focus on 1 stressor-related disorder. Again, these are the 3 that are presented in your book in this chapter. So, as you know, there's some objectives associated with this lecture, so here they are for y'all to read and go through at a later date. I don't know, something you might probably think of. When you think of trauma-related disorders, what might pop into your mind is PTSD, post-traumatic stress disorder. That is one, and is one of the ones we'll talk about. Another one that is associated with the trauma-related disorders is acute stress disorder. It's called ASD, and we'll talk about that as well. So when we look at the stressor-related disorder, it has again, that'll be the 3rd one that we talk about. It is an adjustment disorder. So let's go ahead and get started with the trauma-related stressors first, disorders first. And let's start with PTSD. I don't know, have you ever wondered what it would be like, or maybe you know someone that struggles with PTSD or post-traumatic stress disorder? But this is what someone wrote that is struggling with PTSD. And it starts with this. I'm tired of crying. I'm tired of yelling. I am tired of being sad. I'm tired of pretending. I'm tired of being alone. I'm tired of being angry. I'm tired of feeling crazy. I'm tired of feeling stuck. I'm tired of needing help. I'm tired of remembering. I'm tired of missing things. I'm tired of being different. I'm tired of missing people. I'm tired of feeling worthless. I'm tired of feeling empty inside. I'm tired of not being able to just let go. I'm tired of wishing I could start all over. I'm tired of dreaming of a life I will never have. But most of all, I'm just tired of being tired. When I read that, I felt that was a pretty clear picture of what people struggle with when they are dealing with post-traumatic stress disorder or the acute stress disorder. So let's talk a little bit about PTSD, get a little history about it, and some stats on it. We do know it was formerly known as shell shock or battle fatigue or accident neurosis or post-traumatic neurosis. It actually became aware of it in the 70s when our veterans came back from Vietnam. In previous wars, our soldiers would come back with physical limitations, mainly loss of limbs, usually, or partial losses. With Vietnam, our soldiers came back with psychological issues known as PTSD. So we noticed it in the 70s, and in the 80s, it got recognized as a true mental illness and was put into the DSM-3, which again, remember that is the Diagnostic Statistical Manual that is used in diagnosing people with mental illness. So in 1980, it was included as one of a mental health diagnosis. So what is a traumatic event? Because we're talking about post-traumatic stress, we're talking about the trauma-related disorders. Your text defines anything outside the range of human experience to be a traumatic event. So anything outside the range of human experience. We do see this PTSD be more common in women than in men. What we know is that probably half the population will experience some kind of a traumatic event, and of those 50% or so, 10% will actually develop PTSD. Of those 10%, less than half of them will receive some kind of minimal adequate therapy. What we know, again, is for women, usually the types of traumatic events they experience that might result in PTSD is a childhood sexual assault. It could also be sexual assault, not just as a child, but older, as well as military sexual trauma, known as MST in the military life. For men, usually what happens is that they have been in some kind of an accident, they've had some kind of a physical altercation, or they've physically been abused or assaulted, and in combat. And again, I think as we are having more women in combat, we will see PTSD become a higher thing, diagnosis for those women as well. So here you have a working definition of PTSD. It's a reaction to an extreme trauma. Remember, traumatic event, anything that is outside human experience would be considered a traumatic event. So it is a reaction to an extreme trauma which is likely to cause pervasive distress to almost anyone, such as, and here are some examples of what might be some traumatic events that would fall in this category of outside human experience. Natural or man-made disasters, combat, witnessing the violent death of others, serious accidents, being the victim of torture, terrorism, rape, or other crimes. Several things here. We all have really, just to even, as we talk about natural situations, disasters, getting out, just coming out of the COVID pandemic, actually that week that we had the snow during the pandemic, where people lost electricity, lost water, lives were lost, so much out of our control, but that would be certainly a natural. Hurricanes, fires, any kind of a natural disaster. Witnessing the violent death of others, so it's important to realize the individual does not have to actually go through the traumatic event, but if they witness someone going through a traumatic event, it can indeed result in PTSD. We saw this a lot in 9/11 when the bombing of the Twin Towers, which I know you guys were, generally speaking, were probably pretty young, but there was videos of people jumping out of the top parts of the tower. They chose to take their death by jumping out of a window instead of burning up. People saw that on TV, even if you didn't know anyone, were exposed to it. I mean, we've had several things. The shootings in the schools, in the churches, road rage, where people are beating people up or shooting people. We have experienced in our lifetime a lot of potential traumatic events that people might be experiencing PTSD from. So again, just realize it doesn't have to be something that you have actually experienced, but you saw someone experience could also trigger this. Very important as we think about that. So what are some characteristics associated with PTSD? Well, they can re-experience the traumatic event. They don't have to go through it, but in their mind, they can re-experience it as if it was as fresh as happening at that moment. Typically, they do have sustained high levels of anxiety and can be easily aroused. So we look at things that can trigger them. They can have intrusive recollections or nightmares. I remember when we were at VA hospital, there was one patient that actually had crawled up into the ceiling and moved some of the tile, got up into the ceiling. The firefighters had to come and remove him from the ceiling, and after he was treated and then later was asked, kind of inquired about what was going on, what had happened is that he had a nightmare, and the flashback was so strong that he sought a place of refuge, some place to be safe. And so he ended up going into the ceiling, and he sort of snuggled down between the pipes and stuff that were up there. And when asked why he chose that area, he said it reminded him, it's where he sought refuge during wartime, was in the belly of the helicopter. That's where he felt safe. And so it was a place he was looking for refuge, because the flashback, the nightmare was so real that he needed to seek some kind of refuge. Sometimes they might even experience amnesia to certain parts of the trauma, not remember all of it. Might struggle with depression or even survivors. Now again, remember, we think of PTSD initially with our war veterans, but if you know someone that was driving a car and got in an accident and the individual that was driving did not have one mark on it, but the passenger died. I mean, just recently, hard to even imagine. A couple of days ago, there was a mom and her teenage child in the car. They were fighting about something. The child, while the mom was driving, opened the door, jumped out of the car, and got hit by oncoming traffic and died. Now, it's those kinds of things. Survivors guilt. I mean, there's just a lot associated with potential PTSD. So let's don't forget, it can happen to anyone, any age, and I'll talk about why in a couple minutes why are more people prone to PTSD than others. But there are some factors there. But just realize it is any kind of event that is outside human experience, trauma outside of human experience. Substance abuse is not surprising. A lot of times that's how individuals try to cope with their PTSD. It would be a negative response approach, but it is effective in the sense temporarily for individuals. Anger and aggression might be another thing that they might sort of express. Remember, anger comes from three things. Anger is the result of something. What motivates people to get angry and even to go into aggression is fear. People that are fearful, they strike out in anger. That's how they choose to deal with the fear. People that are frustrated, frustration can lead people to anger. We see this in road rage all the time. And hurt or pain. Someone that's hurting, emotional pain they're experiencing. It's important to realize the depth of the fear, the frustration, and the hurt will determine the intensity of the anger and or aggression that might be expressed. So, and the other thing you might see with people with PTSD are relationship issues or problems, not doing well, having struggles in their relationships. Could be marital relationships, could be friendships, but in relationships in general. Well, what do we know in regards to that sort of our criteria, not just the characteristics we just looked at, but some additional information is important to realize that the symptoms may begin within the first 3 months after the trauma, or it might take weeks, several months, or even years before the symptoms occur. And we've seen this mostly recently in the last couple of decade or two, with the Me Too movement, but where people are starting in their 20s, reporting 30s, 40s, 60s, 70s, reporting that they have been abused, whether it be physically, sexually, emotionally abused, and taking people to court for their actions that happened potentially when the person was a child. But we're seeing that the reason why people are able to do that, as people might experience the trauma in their early life, as they get older, they learn ways to more effectively deal with the stress in their life. And so you'll start seeing people coming out talking about what was done to them later, many times years later, after the actual traumatic event. But it's only because they now are able and equipped to deal or sort of face the traumatic event and deal with it. One of the things that we know, the symptoms, must be present for more than 1 month. This is important. They must be present for more than 1 month. And the symptoms need to cause some kind of a significant issue, either socially, occupationally, relationally, or in any or other areas of functioning in that individual's life. So it really, again, remember this disorder can occur anytime, at any age, to anyone. The second trauma-related disorder is acute stress disorder, known as ASD. This is really very similar to PTSD. in regards to the terms of traumatic events and symptomatology, all of that is very similar to PTSD. What defines ASD from PTSD is this. The symptoms are time limited, meaning symptoms will last 3 days up to 1 month. Generally, what we know is that with acute stress disorder, these symptoms actually do not last longer than 1 month. If the symptoms last longer than 1 month, they no longer are diagnosed with acute stress disorder, but they are diagnosed with PTSD. So again, important to realize with acute, the symptom time limited is 3 days up to 1 month after the trauma. And if the symptoms last longer than 1 month, they no longer are diagnosed with ASD, but are diagnosed with post-traumatic stress disorder. So that's the difference. It's the time frame when the symptoms occur, how long they last, is the major key point in determining the difference between ASD and PTSD. So what are some underlying predisposing factors for PTSD and ASD? Again, the trauma-related disorders. There's psychosocial thoughts, there are learning theory thoughts, there are cognitive theory thoughts, biological theory thoughts. We're going to spend a second on each of these, but let's take a look at the psychosocial theory. Earlier I mentioned that some people might see a traumatic event and just go, wow, that was terrible, and have to deal with it, but they're able to move on. Other people will see the exact same traumatic event and they will not be able to move on. Matter of fact, when they do, it's more towards the diagnosis of PTSD. So what are the factors that cause people to maybe not experience PTSD when related to a traumatic event? There are 3 things. One, it depends on what the traumatic event is. The second thing is, when the traumatic event occurred, what kind of coping skills did the individual have? And the third thing is, what was the recovery environment like? Meaning, what were the people like around them when they told their story about the traumatic event? How were they received? Very important. With our veterans from Vietnam, typically when our soldiers would come home from war, we would give these huge parades. And just acknowledge what they've done, the lives that were lost, and what people sacrificed. And when our Vietnam veterans came home, there were no parades. Actually, it was sort of swept under the carpet, this particular war. And so in regards to whatever the traumatic event was, whatever they saw while they were at war, whatever they did while they were at war, had to do because that was their job. Depending on their coping skills prior to going into the war, how many of those were good, healthy things, and how were they received when they came home. And any one of those 3 things can cause someone to experience PTSD. I think in regards to our veterans, particularly those from the Vietnam era, we did not receive them well. So that recovery environment has a strong impact on individuals, and might indeed be part of the main reason why some of our soldiers are experiencing PTSD. So that's the psychosocial theory. Those are the 3 factors that we look at. Learning theory. This is the idea that instead of dealing with the trauma in a healthy manner, people learn ways to deal with the emotional pain that they're experiencing from the trauma. So this is, even though it's a negative reinforcement, the learning theory is people find ways to deal with that emotional pain through behavioral disturbances. And some of those behavioral disturbances might be where, they just put their head in the sand and they deny any of this even happened, or they find other things. They might release that that pain, that emotional pain through anger and aggression. They might use drugs and alcohol. But again, the whole idea is to help to deal with the emotional pain. That is the learning theory. Negative reinforcement to deal with the emotional pain associated with the trauma. Again, negative meaning not healthy behavioral responses. Cognitive theory is, as we know, your text talks about there are 3 fundamental beliefs that most people in the world believe. One is that the world is benevolent, meaning it is good, a good place, a place that provides joy. It's a source of joy. That's one belief. The second one is that the world world is meaningful and controllable. And the third is that everyone sees everybody else as valuable. They see worth in everybody. Everybody is lovable and good. Those are three fundamental beliefs that many people have. Maybe you don't even know if you even have, but take a second and think. Is the world a good place, and does it provide a source of joy? Is the world meaningful and controllable? Does everybody see everybody with a sense of the same value and worth? What happens is when a traumatic event occurs, these particular beliefs, one, two, maybe all three of them, are invalidated by this traumatic event. And so when these fundamental beliefs get challenged, people can't make sense of it. And so they experience helplessness, which then can lead to hopelessness, which can then lead to PTSD, suicide, if interventions aren't made. So that is the cognitive theory why people might experience PTSD. One or all three of their fundamental beliefs were challenged because of this traumatic event that they experienced. And then the biological theory is the last theory listed for trauma-related disorder potential causes. And on this, it really is suggested that the symptoms that are related to the trauma, the negative symptoms that are related to the trauma, are maintained by the production of endogenous opioid peptides that are really produced in the face of arousal. So what happens is the symptoms that are related to the trauma many times will produce these endogenous opioid peptides, which have, psychoactive properties. What can happen is these can cause a tranquilizing action, can decrease the rage or aggression a person might be experiencing, can cause a decrease in paranoia, can cause a decrease in feelings of inadequacy, actually can serve as an antidepressant action, resulting in feelings of being comfort and control. And so what happens is when these stressors terminate, when the symptoms start getting better, the individual may experience opioid withdrawal because of this biological interaction that has taken place. And these symptoms, again, can bear strong resemblance to those of PTSD. So these are some of the predisposing factors. Again, in many of these cases, I always think it could be a little bit of all, or it's very individualized what some of these factors might be. Nursing diagnoses, we're not going to spend time, your text goes into great detail, but here are a couple that might indeed, that would be appropriate post-trauma syndrome or complicated grieving. Again, remember, complicated, the same thing as dysfunctional grieving, are some examples that your text goes into much more detail about. What do we want our clients during this time? What goals would we want our clients to set? One, can they acknowledge the trauma and the impact the trauma has had on his or her life? That kind of goes with the very last one, where you're actually going to encourage them to verbalize the desire to put the trauma in the past and progress with his or her life. So the whole idea is helping them realize that the trauma did happen, not to put their head in the sand and think it didn't, and that it is woven into their fabric of life, and that it is a part of what has happened and has impacted them and is impacting them. So we really want to help them in that process. We want them to learn some adaptive coping strategies, set realistic goals for the future. We want them to be successful, so we start with successful goals, realistic ones, small realistic goals. We want to encourage them to be successful so they build up confidence and they feel more assured about their future. Help them work through feelings of survivor's guilt. Again, many of our soldiers that came back struggled with survivor's guilt. Why did I make it and my other soldiers did not? My battalion did not. Whatever it might be. So helping them realize survivor's guilt. Attending, we talk about, you guys actually have attended support groups. So again, realizing that those are some great goals for our individuals that are struggling with trauma-related stressor disorders, to get involved in some kind of a support group with similar traumatic experiences. These are some good things that we really want them to do. Helping them learn some more coping strategies really is one way to help them deal with their emotions and with what's going on. So we really want to help them. And again, some of those stress management techniques we might use as coping strategies can be relaxation techniques, can be pet therapy, which is what is used a lot at the VA hospital in Waco on the locked unit, bringing animals for the veterans to see and touch and hold if they're small enough. Mental imagery is another thing that we might teach. Deep breathing, music therapy, art therapy, lots of mindfulness. So many coping strategies we can that are beneficial for individuals struggling with PTSD and ASD, helping them to cope with it. Again, the better they can cope, the better they're going to be able to sleep, the better they're going to be able to hopefully not even have to take as much medication. The idea of flashbacks, the idea of nightmares are very common, but at least reducing maybe the intensity and or the frequency of those occurring is another thing. So what do we do as nurses? Well, we do have obviously the reassurance of safety. They're struggling with the issue of safety. So one way we actually help to do that is if they're on the unit is when it's possible is to assign the same staff person to the same individual. That really does help with them and their environment. The other thing we want to do is we want to be consistent. We want to keep our promises to our patients, to our clients. That is important. Spend time with our clients. We want to stay with our clients during periods of flashbacks and nightmares. We don't want them to be left alone. They want to be in the presence of a trusted individual, and that would be you if you've been caring for this individual. We also want to see about getting some additional information, accurate information, history from significant others about the trauma and about the client's specific response. So we want to talk with family and close friends that have information and would be willing to share that. Again, we're going to help them learn how to decrease the maladaptive symptoms and demonstrate more adaptive coping strategies. So we definitely want to do that. And again, I've already mentioned lots of potential coping strategies that can be very helpful in dealing with the symptoms of PTSD or ASD. Adaptive progression through the grieving process. We definitely want to identify where they are in the grieving process. A loss has occurred, and are they stuck in any of those stages that Ross talks about, or where are they in Wharton's task? All of these, lots of things that we can do to assist our clients struggling with any of these trauma-related disorders. Evaluation, what we do always is evaluate the things that we're doing. Are they meeting the patient's goals? If so, let's continue on. If not, what do we need to do to tweak them so we get back on target? Some of the questions to evaluate is can the client discuss the traumatic event without experiencing panic anxiety? Has the client learned new adaptive coping strategies for assistance with recovery? These are, again, your book goes into more questions to inquire to evaluate how successful you and your client are in moving them forward. But evaluation, again, I can't say this enough, we are constantly evaluating all the time. Okay, the third disorder I wanted to talk about is the stressor-related disorder, and this is the adjustment disorder. This is characterized by a maladaptive reaction. Actually, a good working definition is this. It's a psychological response to a identifiable stressor or stressors. The stress reactions from normal daily events is what falls in this category. So it actually are stressors that people go through on a day-to-day basis sometimes that are kind of normal. Doesn't mean we like it, but we know they happen. And some of those would be divorce. We don't like it, but we know 50% of people get divorced. Failure or rejection, maybe dealing with chronic illness, maybe having marital relationship conflict. These are normal things that happen throughout life. So they are known as normal daily events. But some individuals do not cope well with some of these daily normal events. And that's when people might end up being diagnosed with adjustment disorders. The thing about adjustment disorders, like with PTSD and ASD, symptoms occur within 3 months of the stressor and last no longer than 6 months. So again, there is a time frame here and what the symptoms that they might present with. And again, your textbook goes in to the symptoms they might present with, but there are some very common types of adjustment disorders that you might see a patient diagnosed with. One, they might have adjustment disorder with depressed mood. Now, this is the most common adjustment disorder we see diagnosed. Usually the person presents with depression, they're depressed, they're tearful, they have feelings of hopelessness. There's just, they are extremely depressed. So adjustment disorder with depressed mood, again, remember, symptoms occur within 3 months of the stressor. Let's say they get divorced and they last no longer than 6 months. Let's say the individual presents in that time frame, the symptoms last 6 months, then they would be diagnosed with depressed mood, adjustment disorder with depressed mood. Adjustment disorder with anxiety, as you can probably guess, this one predominantly the individual presents with symptoms of anxiety, neurosis, worry, jittery, symptoms associated with anxiety. Some might present with both anxiety and depressed mood, so that's known as mixed anxiety and depressed mood adjustment disorder. Disturbance of conduct, so they might be diagnosed with adjustment disorder with disturbance of conduct. And in this is when an individual is violating the rights of others. Truancy might be part of this equation. Actually, fining might be part of this. But disturbance of conduct. Sometimes people might be diagnosed with adjustment disorder with disturbance of conduct, the things we just talked about, as well as disturbance of emotions, that they have maybe depression or anxiety associated with their behaviors. Related to bereavement, adjustment disorder related to bereavement, this again may take a little longer, so it may not be over in 6 months, but you need to see what is going on, what are the losses, how often have they occurred, will help determine if indeed if this is an appropriate diagnosis or not. And then unspecified, adjustment disorder unspecified. Anytime you see the word unspecified, it just means whatever the person is experiencing is similar to something, but it is not sufficient enough to be diagnosed with any specific diagnosis associated. So it could be they're presenting with some depression, but it's not enough to meet the criteria. So they might get adjustment disorder unspecified. A lot of times in this particular diagnosis, you'll see that the individual presents with physical complaints. A lot of times they do withdraw from relationships. They have some issues at work or school, if they're in school, some performance issues. But usually they don't present with any kind of emotional or disturbance of conduct in their behaviors. So those are the adjustment disorders, the different types of adjustment disorders you might see. What then do we know are some predisposing factors associated with adjustment disorders? Well, there are 3: biological theories, psychosocial theories, and transactional model of stress or adaptation. So let's take a look at each of these. The biological theories, their bottom line is genetics may play a part in an individual's maladaptive response to stress. Bottom line, there could be a genetic factor with that. Psychosocial theories, the thought is that there is some kind of a childhood trauma that occurred, which during the time caused the individual to have an increase in dependency, and in that it caused their ego development to be retarded or to be arrested. And so at this point in time, they are not able to progress developmentally due to that. And so that is one of the reasons why they might have some adjustment issues. They might, depending on when the stressor occurred, the development stage and the timing of the stressor, what was it when it occurred, where the individual was mature, their mature level at that point, what kind of coping skills do they have they developed already? What types of support systems, when the stressor occurred, what kind of support systems did this individual have? If they were lacking support systems, then they indeed could end up being diagnosed with an adjustment disorder. And they also might have, due to the stressor, have dysfunctional or complicated grieving process in which the individual gets stuck in the denial or anger stage, according to Kubler-Ross. So they have inadequate defense mechanisms to complete the grieving process. So these are the psychosocial theories associated with the adjustment disorders. And then transactional model of stress and or adaptation. This is actually stating that it looks at the interaction between the individual and their environment. And that includes the type of stressor that they experience, their situational factors, again, what kind of support systems do they have, what kind of coping skills do they have in place, and also their intrapersonal, I-N-T-R-A, personal factors. How do they view themselves? Are they aware of their strengths and their weaknesses? If so, they would have what is known as a high intrapersonal intelligence, or are they not aware of their strengths and their weaknesses? If that's the case, then they are individuals that are known to have interpersonal conflict, emotional stress. They do not or are not aware of their strengths and their weaknesses. Again, this is probably, when we look at all predisposing factors, it can be all parts of all of these, maybe some more so than others, but these are the ones that are listed for adjustment disorder. Nursing diagnoses, again, not to, they're listed here. Your text goes into great detail about this, but these are some appropriate ones for this particular disorder. What indeed would we want our client to shoot for, what we want them, their goals, their outcome criteria? One, that they would verbalize acceptable grieving behaviors, that they would realize what those behaviors are, where they are, and what the stages of grieving, what behaviors are associated with that, and what are considered, there is a normal grieving process, what that would be. That they would demonstrate a reinvestment in the environment. Bottom line, they want to get back in to the routine of life. Their interest in living has been heightened. Their anhedonia, the loss of joy for things that used to give them, things that they used to do that used to give them joy. Their anhedonia is dissipating, meaning that they're starting to find things in life that they can view as joy-giving. They're able to accomplish their ADLs independently. They're demonstrating their ability to function adequately, so possibly being able to work back at school, going back to class, going back to their job. They are accepting changes in health status. A lot of adjustment disorders are individuals, older individuals, that have chronic diseases and how that impacts them. So dealing with learning how to adjust, having a medical diagnosis, which is going to be a lifelong chronic disease to have to deal with. So accepting the change and learning how to live with it. Setting realistic goals for the future. Obviously, very important that the goals are measurable and achievable and appropriate for their particular situation. They demonstrate the ability to cope effectively with change in lifestyle. So again, it's all about, we'd like them to have some very good, effective coping strategies to help them not just survive life, but to thrive in life, right? That's our goal. We want patients to achieve. We want them to experience a quality of life they are deserving. So these are our criteria that we look for our clients. So what about what do we do? How can we do? What interventions would we want to implement with this? Well, adaptive progression through the grief process is this one thing. Identifying where they are, and if they are stuck, and helping them learn how to move through that, or if they are reacting in the normal process of grieving, but adapting the progression, helping them move through the grief process, help the client to achieve acceptance of a change in the health status. And again, part of that is by educating them, giving them all the information we can and know about that, helping them brainstorm in options for them, things that they might do. Brainstorming. We are not going to give them answers. We are not going to do that. But what we are going to do is that we are going to help them consider all options, and they choose what's what. And we want to assist them with strategies to maintain anxiety at a manageable level. Obviously, if we get their anxiety taken care of, where they don't even have it, that would be wonderful. But the ways to help them manage their anxiety is really important for these individuals. And this all begins with the trusting relationship, right? That rapport, that therapeutic communication, that therapeutic relationship is so important when we're really wanting to assist our clients. Evaluation, the same as it was for the trauma-related disorders. Let's evaluate what we're doing. Is it meeting clients' goals? And if not, let's tweak it. If so, let's continue. Some questions you might want to ask to help evaluate. Does the client demonstrate progression in the grief process? Does the client discuss the change in the health status and modification of lifestyle it will affect? Does the client set realistic goals for the future? All of those, again, your text has more, are listed to look at the adjustment. Treatment modalities, let's kind of start wrapping this up. And for the trauma-related disorders, PTSD and ASD, cognitive therapy is definitely one of the types of therapy approaches that we would really want them to experience. Again, this is really helping them evaluate their thoughts. Are they rational, irrational, and helping them, if they're irrational, learn ways to make their thoughts more rational. Prolonged exposure therapy, this is a lot like flooding or implosion therapy, behavioral therapy, in which you expose the individual to their stressor in very short periods of time, and you do that through actually educating them, teaching them or retraining them, maybe teaching them some breathing, effective breathing skills for relaxation, helping them to imagine the trauma, and then actually exposing them in the real world to their trauma, life situations. Can be very effective. Prolonged exposure therapy. Group and family therapy is another. Eye movement desensitization and reprocessing. This is also known as EMDR. The way it works is not 100% understood, but it has something to do with, it involves the rapid eye movement of our clients, and why they are having rapid eye movement take place. They are able to discuss the painful trauma that they've gone through, however, not experience the painful emotions associated with it. It is amazing. It's very effective in trauma-related disorders. They use it a lot with PTSD and ASD. There are 8 phases. Your textbook goes into detail about this. Just again, it's very effective treatment modality for people struggling with these disorders. And then psychopharmacology. Bottom line, just realize that antidepressants are the first line, actually SSRIs, antidepressants are the first line of treatment for PTSD. That can be Paxil, Zoloft, tricyclics, MAOIs also, but SSRIs are the first line of treatment for PTSD and ASD. Anti-anxiety medicines might be used, Presolon, like Xanax. Antihypertensive, beta blockers, Inderal, sometimes are used. Alpha receptors also might be used. Clonidine is one that falls in that category. Are some of the drugs that you will see associated with them. In regards to treatment modalities for stress-related disorder, the adjustment disorders, individual psychotherapy, family therapy, behavior therapy, self-groups, crisis intervention, and psychopharmacology. Now, I'm guessing all of these from crisis intervention on up, we should be familiar. I'm familiar. I'm hoping y'all are familiar with these particular psychosocial approaches. Psychopharmacology, it's important here to realize people diagnosed with adjustment disorder usually are not treated with medications. Okay, so let me say it one more time. People with adjustment disorders typically are not treated with medications. One is because, again, remember, this is typically is no longer than a 6-month time frame. So it's a temporary event or effect. So you don't want to start getting people hooked on drugs if indeed they don't need them. The other thing is, if you put people on drugs, either antidepressants or anti-anxiety drugs, it might mask what the real problem is, thus slow down moving through the problem. So that's another reason why. And the other one is that psychoactive drugs have a potential for physiological as well as psychological dependency. So we don't want to start people and give them another problem, an addiction issue. So people with adjustment disorders do not typically receive any medication. It's all taken care of through the above things listed on this slide approaches. If, however, one's anxiety and or their depression is so strong and it's hampering their getting benefit from any of these other types of therapies, then and only then would medication potentially be added to their regime, but only then and very temporarily. Just a couple of things, words to food for thought, SSRIs, again, because those are prominently used first line for the trauma-related disorders. Here are some examples of SSRIs you see that you probably already pretty familiar with. Also included in what you might see in these would be Celexa and Lexapro also would fall in this category. What I want you to also realize that SSRIs might cause some contraindications. So these are just a few thoughts about SSRIs and other medications, some over the counter, some prescription. But just be aware, many of our patients do take over-the-counter medications, a lot of things that are natural, so they may not think about mentioning it to us when they tell us they're taking it, or it's just a supplement. But we know that St. John's wort is definitely needs to be avoided. So anyway, bottom line, we need to get a really good history on what medicines they're taking. And we ask not only prescriptions, we ask over-the-counter and supplements. Again, St. John's wort is a good example. Mixed with the SSRIs could cause serotonin syndrome. Again, we want to be cautious. We don't want that to happen. So just be aware. Another thought for you just to remember when you're dealing with SSRIs in general. As we're bringing this particular class to a close, something to think about. This is a good time to make time for good friends. Encouraging you to do that. There's no time like the present. Thanks again for this. Have a great rest of your day. I'm going to stop sharing and let's see if I can at least sign out here and say, guys, listen, have a great rest of the day. If you have any questions, let me know. Don't forget, take care of yourself. You can't get what you don't have. That's the truth. Take care. See you at the next class. Bye-bye.